And now it is my pleasure and honor to introduce Dr. Debra Lynch, class of 79. Dr. Debra Lynch earned her doctorate degree in counseling psychology from Seton Hall University in 1999, a master's degree in clinical psychology from Fairleigh Dickinson University in 1982, and graduated from Douglas College in 1979. She spent her career working with adults with developmental disabilities, and over her career, she developed a specialty in developmental disabilities and geriatrics with a subspecialty in Down syndrome and Alzheimer's disease, presenting this topic at numerous conferences and agencies. After 29 years in state service as Director of Psychology at a number of developmental centers, Dr. Lynch retired in 2013. Dr. Lynch has served on numerous boards. She served from 2012 to 2018 on the Volunteer Guardianship One-on-One Board and was on their executive committee as secretary. She has been on the Associate Alumnae of Douglas College Board since 2009, serving as Vice President of Alumni Relations and as a member and chair of numerous other committees. She was on the Rutgers Board of Trustees from 2011 to 2024. She is currently on the board of the Children's Health Institute of New Jersey, part of Rutgers School of Medicine. Now, please welcome Dr. Lynch, our 2025 Zagoren Lecturer.
Thank you, Lee. I just want to thank Lee and the committee and Lauren for choosing me as this year's Zagoren Lecturer. It is quite an honor. I am going to jump right into the lecture because I've got a lot to cover. So the first thing I want to really make clear, and everybody will be relieved, dementia is a disease condition and is not a normal part of aging. You may have some mild memory loss, which is normal with aging, forgetting specific dates and names, but usually that forgotten memory is recalled a short while later. So dementia is a disease of the brain that causes gradual deterioration of a person's ability to think and act independently. Loss of or a decrease in intellectual functioning along with an impairment in memory. Dementia is a term used to represent a group of symptoms. These symptoms include, but are not limited to, confusion, memory loss. Usually short-term memory loss is most affected as opposed to long-term or immediate memory, personality change, impaired judgment, and impaired reasoning ability. Alzheimer's disease is just one disease process with dementia as a symptom. So a lot of times you'll hear Alzheimer's disease and dementia used interchangeably. It is not. Dementia is a symptom of Alzheimer's disease, but it is also a symptom of numerous other disease processes which need to be continued. Next. Next one. Okay, so as you can see here, there are many other disease processes that cause dementia. And some of these are reversible. So therefore, a thorough medical workup by an expert is essential. I always say that if you go into your primary care physician and they diagnose you with Alzheimer's disease or dementia, please, 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 if you take nothing else away from this lecture today, is go to a gerontologist or a neurologist to get a definitive diagnosis. Because some of these things like vitamin deficiencies, thyroid diseases, depression, if they're treated, the dementia either improves or goes away. Next. The degenerative diseases are the ones that are progressive and there are no cures for. And all of these have dementia as one of their symptoms. Think of dementia as if you had shortness of breath. There are numerous causes for your shortness of breath. You know, you could have lung cancer, you could have a bad cold, you could have asthma. A doctor is going to want to find out what the cause of the shortness of breath is, just like a doctor is going to want to find out what is the underlying cause of the dementia. Okay, next. All right, so some symptoms of dementia: recent memory loss, difficulty performing familiar tasks. And I'm going to go into a lot of this more in depth as we go along. Problems with language, disorientation of time and place, not knowing if it's morning or afternoon or where you are at the time, or whether did you just eat lunch, or and maybe you did and you don't remember that. Poor or decreased judgments, problems with abstract thinking, misplacing things, changes in mood and behavior, changes in personality, and loss of initiative. So some of the things that we look at is with recent memory loss, are they repeatedly asking questions and the person doesn't remember the answer, or they don't remember that they did something? Difficulty performing a familiar task. So you have loss of activities of independent living, not being able to do, again, things that they were able to do before, make their own meals, clean the house, things such as that. Problems with language. They may forget words, and we all do that, so I don't want people to panic. But again, when we forget a word or we struggle for, that's normal. It's they substitute inappropriate words, or the word doesn't come back to them, or they don't realize that they forgot the word. Or the person that you're talking to is, it sounds like gibberish to you. Disorientation of time and place. Maybe they can't find the room or the bathroom anymore. Poor or decreased judgment. Are they wearing several shirts or socks, putting on duplicates of things? Wandering, walking away from home, misplacing things, putting things in odd places, keys in the refrigerator. But the difference is, and I don't want people to panic because people go, oh my God, I do that all the time, is you look at it and you go, oh, I put my keys in the refrigerator. They open it up and they don't think it's an issue that their keys are in the refrigerator. Rapid mood swings, oftentimes you will see. Changes in personality, becoming confused, irritable, suspicious, or fearful. Loss of initiative, become very passive, needing constant cues and prompts to get them involved in activities. One of the things that you may see with somebody with dementia is some days you will see the flashes of the old person, the old self, the person that you used to know. Dementia is a heartbreaking disease because the person that you know slowly slips away. And every once in a while, you'll see a flash of the old person where they're coherent, you can have a conversation with them, and then it slips away again. I always say that's one of the cruelest parts of the disease. It's almost a teaser, a reminder to you of the person that you're losing. Unfortunately, this happens quite frequently when where I used to work. I'd have staff come up to me and go, I went to see my mother. And we had this big conversation and this was great. Maybe they just misdiagnosed her. And I have to say, no, this is a very normal part of the disease process. One of the things you also may see is an increase in frustration and tolerance levels, and that will often result in aggression and temper tantrums, especially when asked to do something they used to be able to do, because it's very frustrating, especially at the beginning of the disease process. There's still some awareness that I should be able to do this. I know I used to be able to do this, and I can't do it anymore. And the person gets very frustrated and very upset. Okay, so now that we know what dementia is, what do we do about it? Next. Yes, keep going. We're going to skip the stages. You're gonna get all of this. So we're gonna skip some of this. I wanted you to have this information. But we don't have time to go through all of this. So keep going. Okay, right there, stop. Thank you, Lizette. All right. So one of the things that we need to do with someone who, oh, right there, with someone who has dementia is we need to manipulate the environment. And we need to continue to make changes as a person's skills deteriorates. So what worked 6 months or a year ago may need to be modified and changed. Also, as you see problematic behavior, I always say, you know what, that behavior eventually is going to change and go away. And they're gonna develop a new problematic behavior. It's as the disease progresses. If for those of you who might be so familiar with behavior modification, where we try to apply techniques to change the person so they no longer engage in behaviors. We do this with our children all the time. That doesn't work with somebody who has dementia. We need to change the environment in order to minimize the behaviors that we're seeing. So some basic techniques that we're going to use with somebody who has dementia. Do not argue, confront, or try to convince. Their ability to understand what they're doing is very minimal. And it's only very confusing for them. And more than likely, you're going to get them upset. Realize that the individuals are not being stubborn, mean, suspicious, or ungrateful on purpose. They don't have an understanding of the world around them anymore. The world doesn't make any sense, and they're frustrated. If you can set up a routine to follow, that is extremely helpful. May need to eliminate the need for choice making. Because again, you're asking them to do something that is very frustrating for them. Calm, quiet environments are really important. And do not try to correct an individual's reality. Reality orientation is not helpful for those with dementia. I always used to tell, when I gave this talk, I always say, if they're calling you Aunt Lucy, guess what? You're Aunt Lucy today. Because in their mind, you are. And if you try to correct them, again, it's confusing, it's frustrating, and you will oftentimes see a reaction from that. Next. Also, do not rush or hurry a client through tasks and activities. If you're attempting a task or activities, do not correct the individual if they're doing it the wrong way. As long as they're not going to hurt themselves or others, just let them go ahead. If the individual is becoming upset, try to distract them. By changing the subject, the individual might forget the subject. We can use their lack of short-term memory to our advantage. So if we can distract them, oftentimes they will forget what was upsetting them in the moment. Oftentimes the individual loses the ability to keep track of time. So they have no idea whether they did have breakfast or not, or what meal is next, or what's supposed to come next in the course of a day. A rocking chair or music may be relaxing and calming. And I always say music that they find relaxing. You know, those of us who are baby boomers grew up with rock and roll. That might be what that person likes to listen to and likes to relax to. It might not sound like it's relaxing, but if they enjoy it, that's what you should be playing and offering to them. Oftentimes, simple household chores can reduce the potential for agitation. I worked with individuals who we would give them, they'd start to get agitated, we'd give them a broom and let them sweep. Simple task, they knew how to do it. And they would do it for half an hour to an hour because this was something they were familiar with and they felt successful in doing it. Okay, next. All right. Well, here we go. Communication, which is often really difficult. We Americans have a tendency to speak very, very quickly. And what we need to do when we're working with somebody with dementia is slow down, speak slowly, give the individual time to respond, and try to make sense of what we are saying. You throw too much at them, they're going to get upset and agitated. The individual may say one word and mean another. Oftentimes you need to try to figure out what it is that they're actually trying to tell you. And then you can repeat back to the person, oh, you mean this, and it is somewhat guesswork. If it's somebody you have a close relationship with and spend a lot of time with, oftentimes it's easier to guess what it is they mean. When you're interacting with somebody with dementia, gentle touch to keep or get attention is often very, very helpful. So they are focused on you. They are easily distracted. You want to stand directly in front of the individual so that they see you. Don't approach an individual from behind you. You very well may startle them. They will become aggressive because, again, dementia is a disease of the brain. And as the brain is slowly deteriorating, they're having a harder time working out what's going on in the world behind them. You approach them, they may just react in a fight mode because that's how they perceive somebody sneaking up behind them. Use gestures or visual aids if you need to. And we will go into this a little bit more later on. Present one idea at a time. We're used to giving multi-step tasks to people. With somebody with dementia, one step. Once they've completed that, then you can give the instruction for the next step. Avoid asking questions because that takes a lot of processing that they don't necessarily have anymore. And then it becomes frustrating when they can't give you the answer. Give direct statements. Don't ask them if they want to go to dinner. Say, it's time to go to dinner. And use a normal, calm tone of voice. If you get upset, if you get excited, they are going to react off of your emotions. So they oftentimes will become excited or upset. Next. Okay, next. Bathing. Okay, the bathroom is one of the worst places to have somebody get upset and agitated. Think about our bathrooms. Our bathrooms are full of tiles and hard surfaces, and oftentimes there's not a lot of room to move around. And if you're bathing somebody, they're wet and slippery. So it is like a nightmare of a place for somebody to get upset and agitated, and that you have to work with them physically. So before you even start the process of bringing them into the bathroom, I just saw something that said they can no longer see the slides. So I don't know if we can reload them. So you want to have everything ready before you start the process. It's like working with a young child. You want to go and have, whatever you need in the bathroom set up before you bring them in. Their towel, the washcloth, whatever soap, shampoo we're going to use, the clothes that you're going to change them into as they get out. You want to have that all set up and ready to go so that you are not distracted, that you do not have to leave the room. You want to be calm and gentle. You're not going to rush or hurry. One step at a time, and let the person know what you're going to do. If you have to assist them, especially in the bathtub, let them know, I'm going to wash your back, we're going to wash your hair now. I'm going to put the shampoo in. So they're not, again, not startled. Don't try to convince an individual that the bath is needed. Again, oftentimes they will fight you. Showers are the worst. There is something about water coming down on their heads that is very, very upsetting to someone with dementia. You probably will have to start giving baths. If the person refuses at some point to get into the bathtub, you might have to come back later. You might have to come back the next day, the next morning. If there's somebody else in the house, you may give it a break and have that person try, because for whatever reason, they may be responding better to them. Unless they're having a major incontinence problem, sit down and think, do we really need to bathe them every day? You may need to resort to, sponge baths in between with a bath every few days. In the tub, you only want to use a few inches of water. You don't need a lot of water. It makes things a lot more difficult when you're trying to get them in and out of the tub. And it's also less disorienting. The other thing you may need to do if somebody is refusing to enter a bathroom is cover the mirror. When you think about it, most bathrooms, when you walk in, you have a mirror right in front of you as you walk in above the sink. And all of a sudden, the person's refusing to come in. All they see is there's a person in the mirror. They no longer recognize themselves, and to them, there's somebody in that bathroom. So they're like, I'm not going in there. I know I'm not supposed to enter a bathroom with somebody else there, so I'm backing off. So you may need to cover the bathroom. The other thing that you may need to do too, especially with men, is revert back to if you've got boys when you were potty training them, is those little targets that you would put in the toilet bowls. Think about our bathrooms. A lot of everything is white. This is an elderly person. They're probably having vision problems, probably having problems with perception. And now you're asking them to aim at another white object. Change the color of the toilet bowl seat. Make it a different color than the actual, than the rest of the bathroom, so they know where they're aiming. Because that becomes a big problem where they all of a sudden are missing the toilet. Okay, next. Dressing and grooming. So you may need to choose clothes for the individual. What we want to do is take into consideration what the individual's preferences were. If this is somebody that you knew, that's a parent or a relative that you grew up with, and so you sort of have a sense of what was it that they liked to wear. Or, did they like to have a nice blouse on with a pair of slacks, or were they a sweatpant type person? Try to dress them in the clothes that they would have chosen themselves, if you know that at all. Even though they might not be able to choose it, there's a sense of they're comfortable in these clothes. These are the clothes that make them feel good. So you want to try to dress them as appropriate, very close to what they would have chosen in their own lives. Lay out the clothes in the order that they will be put on. Start with the underwear and then the next layer and right down the line. And if they can get dressed themselves, or at least partially, you want to allow them to do as much as they can themselves. Soon as though they start to struggle, or get frustrated, you can step in and help them. Use simple garments if they're having problems. Things with large zipper pulls, try to avoid anything that gets pulled over the head. That's very disorienting to have all of a sudden something come over your head, you can't see anything, and now you have something being pulled over your face. I would suggest avoiding that. Elastic waist pants oftentimes are very helpful and will also become helpful in the bathroom also. Don't rush or hurry the task. You're going to see a lot of things being repeated here. Rushing or hurrying a task is just a recipe for disaster, because you're in a rush, you're trying to rush them through it, and they're going to get agitated. It's going to take you twice as long, if you can get it done at all. So if the individual starts to become frustrated, back off, wait a few minutes, and then reapproach them. Oftentimes, because of their memory issues, again, working that to our advantage, they have forgotten about what upset them and what frustrated them. And using this approach, you're actually, it's going to take less time, because now you're not going to have to calm someone down who has become very agitated. And the agitation in somebody who has dementia can last a while. Okay, mealtime. Again, simple one-step directions. Okay, pick up your fork. Pierce your meat. Put the meat in your mouth. You may actually have to walk them through step by step what it is they need to do. Limit the number of choices. You may need to eliminate choices to the point where you're not asking the person, do you want this or this? Even if it's only 2 choices, you may just say, okay, this is what we're having today. Again, trying to give the person food, though, that you know that they liked before they had dementia. God forbid I get dementia and my husband tries to feed me broccoli. I am going to be very upset. I don't care how bad I am. So you want to give them food they like, because their food preferences may not change. At some point, it may be easier to use finger foods. Things like sandwiches, simple foods like chicken nuggets. If you notice, a lot of this stuff, for those of you who have raised children, it's a lot of stuff we do with young kids. When, again, finger foods, when they're first learning to feed themselves, they don't have the dexterity to use a fork. So, we allow them to pick up individual foods to put in their mouth. And that's what we may need to do with somebody with dementia. Oftentimes, individuals lose their ability to discriminate between very hot and very cold food. Of course, the very hot is a lot more dangerous. So you need to make sure, if you're giving them a cup of coffee or a cup of tea or something that's really hot, or even their food, you need to make sure that that food is at an appropriate temperature, that they're not going to burn themselves. With drinking from glasses, oftentimes you just want to fill the glass half full, because they have a problem. We all have a sense, as adults, how much we need to tilt the glass in order to drink it without spilling it all over ourselves. They lose that. So maybe half full. Bendable straws, often, if they're having problems. And also, they will have an inability to discriminate. If you put something in like a paper cup, like if you decide, oh, I'm only going to use a small amount of some sort of a cleaning project, a and you put it in a paper cup, they're not going to know and be able to discriminate that that isn't something to drink. Or using a plate for something. I worked in a developmental center, and I had to constantly tell staff, you can't put non-edible things in cups or on plates, because our individuals, there's a good chance if you're not right there, they're going to attempt to eat them. Next, toileting and incontinence. Okay, incontinence is one of those issues that seems to be a breaking point for a lot of people who are taking care of somebody who has dementia. And oftentimes that's what will get the decision made that they need to go to an assisted living or a nursing home. And if you look at this bathroom here, look at it, it's all white and all white hard tiles. So you can understand if somebody came into this, would have and had perception issues and vision issues, having a hard time finding where anything is. They oftentimes will have a hard time finding the bathroom, even in a house that they've lived in for a long time. So they putting a sign on the door, not necessarily a sign that says bathroom, but maybe a big red circle, so that they know that's where I go. This often is helpful early on in the dementia process, when they can still have some ability to learn a little bit and know that that red sign means that's where the bathroom is. Somebody told me a story about somebody who they were taking care, and they couldn't figure out why the person kept urinating and defecating in the kitchen sink. They couldn't find the bathroom. They had enough left to know that not to defecate or wet themselves, but they couldn't find the bathroom, and that's what was the next best thing, because they knew where it was. Try to use a toileting routine and schedule. Watch for signs that the individual may need to use the toilet: restlessness, squirming, that might indicate, again, that they need to use the toilet. Again, for those of us who have raised young children, it's very similar to what we did when we were trying to toilet train our kids. They may need help removing clothing, especially if it's not easy to remove clothing. If you've got buttons on their pants or snaps or zippers, they may no longer be able to maneuver that. So you may need to help them. It's not uncommon for the individual to sit on the toilet with their clothes on. They may need help getting correctly positioned. Again, the equilibrium may be off, just as normal aging. Oftentimes, your body doesn't quite work the way it did before. So you may need to help them get positioned on the toilet correctly. Restrict fluids and salty foods 2 hours before bedtime. And the salty foods is the one that everybody forgets or doesn't realize how important that is. The thing with salt is that it sort of like sucks up the water in your body, and this is non-scientific explanation. They suck up the water in your body, and then all of a sudden it lets it loose. So if you have salt just before you go to bed, all of a sudden in the middle of the night, you are going to need to use the bathroom. And so it will result in a lot a couple of things, the person wetting the bed, or them trying to get up in the middle of the night, and that's when you see a lot of falls happening. And we have had people who have gotten up in the middle of the night to use the bathroom and then wandered outside and not gone realizing to go back to bed because in their mind they're up. You want to place the individual in clothing that is easy to remove with as few layers as possible. So depending on where you are in the process of the dementia, you may actually want to think about, like, what can we eliminate? We have social norms that we don't even think about. Are they absolutely necessary? So do we need to actually have underwear? Can we just have their trousers or pants on, so when they go to use the bathroom, all they have to do is take down one thing rather than trying to work on taking pants down and taking underwear down? So again, a lot of this is all based on an individual. Some people may never need that. Got to look at the individual, what the problem is. Why are they having problems getting to the bathroom on time? Or if they're in the bathroom, why aren't they making it onto the toilet? It may be the fact that they've got too many layers of clothing on. Next. Okay, wandering. This is a huge problem. It is dangerous. So a lot of people with dementia like to pace. So we need to find a secure place where the individual can pace and move, and they don't necessarily have to leave the house to do it. Because again, if somebody gets out, and we've heard so many cases of, you'll see the signs up as you're driving on the turnpike or the parkway, look for this individual, look for, a car license plate number, individual is cognitively impaired, because sometimes people remember driving a car is considered a long-term memory. So they may be able to still get in the car, drive it, which is very scary. A gym that I used to belong to last winter, there was a gentleman with dementia that worked out at the gym, and he wandered off, and his caretaker didn't see him wander, and they found him the next day in the woods. It was very cold, and he had passed away. So again, this is a very, very dangerous behavior. One of the things you can do is an ID bracelet engraved with memory impaired and the person's name, address, and phone number, or a tile-like device. I mean, we have these, great devices now where you can take a tile and tie it to their sneaker lace. So if they do wander, you can track them. Or it be put in their pocket or on a keychain or something that that they're going to carry with them. So technology is always advancing, and we needed to use it to our advantage when it comes to working with people with dementia. If an area needs to be locked, put locks at the very bottom of a door or very top, because long-term memory for somebody with dementia means the lock is right near the doorknob. It's either on the doorknob or above the doorknob. So they're looking for that lock. They're looking for that lock in that area. So if you move the lock very high or very low, that's not a normal place for a lock. They're not going to be checking it. In fact, I had a laugh when we moved into our new home. There is a lock very low on the door. And I said to my husband, oh, look we've got our dementia lock on the door already. Because it's in a odd little place for a lock. Or child-proof knobs. Because again, they're not going to know how to use it. They're not going to be able to figure it out. And a lot of times those child-proof knobs take some grip strength to get them open. So that can impede somebody from wandering out a door. Movable screens in front of a door. If they don't see it, they're not looking behind to see a door. I had spoken to somebody who came up with an ingenious idea. They put police tape in front of the door, on the door, because long term, the dementia person knew not to cross that. So that was an ingenious idea. And then if the person is trying to get out, what you want to do is move them away from the door slowly and gradually. Talk to them, distract them, get them moving in the other direction. Because if you just try to very abruptly move them away from the door, you're gonna get pushed back. They're gonna get angry. They're gonna get frustrated. Sleep patterns may change. A lot of times wandering at night, and they sleep during the day, which as a caregiver is tough. Because now you're not getting sufficient amount of sleep and care. As a caregiver, your job is tough enough and is stressful enough that the last thing you need is a lack of sleep later on top of it. It is not unusual for a caregiver to pass away before the person with dementia does, because of the stress. The absolute stress of caring for someone with dementia. Okay, next, sundowning. Okay, so a lot of people have heard about this. So sundowning is a worsening of problems in late afternoon, early evening. You'll see increased confusion. You'll see agitation, anxiety, along with pacing, wandering, wringing of hands, all those type of behaviors that somebody who is anxious and upset would engage in. Nobody's quite sure why. I've heard a whole bunch of different explanations that possibly the sun going down, sets a person, gets them off kilter. I've heard explanations for people that are in facilities that's when change of shift happens. So that change of shift is very disorienting, and it's very confusing. Change of shift. You got all these people coming in, you got people going out, people are passing along information. But it also happens in people who live in houses with their caregiver, their significant other or whatever. So nobody's quite sure why sundowning happens, but it is a quite common phenomena. So one of the things you want to do is rearrange their schedule so that there are less things that take place in the evening or late afternoon. That's not when you're going to want to maybe bathe the person. You may want to put off maybe having them eat earlier or later, so that it's not during their period of agitation. Try not to schedule doctor's appointments during those times. Because again, you're going to have a real hard time getting someone to cooperate if they're going through sundowning. Allow the person to pace, to work it off. And again, soothing music, rocking a beanbag chair, oftentimes is very comforting. Again, that music, what is the music that they find soothing? Oftentimes it's not, what people think it is. Know what they used to like when what they used to listen to, what they used to like. that's the music you want to offer. Next, hiding things in suspiciousness. So you're going to see, oftentimes they'll take others' possessions. Again, they have no impulse control. They see it, they want it, they're going to take it. If they're in a nursing home facility, they can get them in trouble with their other residents that are there, who oftentimes have very little tolerance for that behavior. If you're taking somebody out and you're in a store, they don't mean to shoplift, but if they see it, they want it, they'll take it. So it's something that you need to be aware of. They may accuse others of taking their possessions. Or if they've taken somebody else's possession, they'll refuse to give it up. So oftentimes what you're going to need to do is sort of distract them, wait a while. Maybe when they're at sitting down to eat, you can go and then put that item back in its rightful place. Oftentimes, somebody with dementia will see that they will think others are talking about them. And they'll go through their own possessions over and over and over again, checking to see what is there and what is not. They will hoard items, is also common. So what you want to do, if you see this behavior, and again, my youngest grandson, we used to always have to check the garbage cans because he loved to throw things out. Check waste paper baskets before you empty them. Because they know you throw stuff away, you get rid of stuff in waste paper baskets. Oftentimes they have a favorite hiding spot. A drawer. Maybe they have a little chest, a jewelry box or something that they like to hide their favorite things in. So you need to check that if something is missing. If they think one of their items is missing, don't try to argue with them or rationally explain a disappearance. Just agree. Oh, yep, it's missing. Let's see if we can find it. Help them look for it. And then as you're helping them look, you can distract them into maybe moving in another direction. Don't whisper. We, without dementia, get very suspicious if we hear people whispering behind us that we think people are talking about us. It is heightened in somebody who has dementia. You want to distract the individual with other activities. So if they're, again, thinking something has been taken from them or people are talking about them or whatever, see if you can get them to move on to other activities. Use their short-term memory and easily being distracted to move them along and cut down on any possible agitation. A person who is paranoid has not gone crazy. They live in a world in which each moment is starting over with no memory of the moments that went before. Think how disorienting that has to be. So you now have things for them, things disappear, explanations are forgotten, and conversations make no sense. When you look at it that way, you can understand paranoia and suspiciousness. Okay, so we're going to move on a little bit quickly because I just got my 5-minute warning. Okay, so improper sexual behaviors. This is another thing that will get people put into an assisted living or into a nursing home. So I always say it's very cute when little 3-year-old Johnny strips naked in the middle of the family Christmas party and runs around. Not so much when grandpa does it. But it's very difficult to not overreact, especially if you're in somewhat of a group setting. Try to remain calm, try to calmly get the individual a robe or clothing, redirect them. Oftentimes you'll see inappropriate masturbation and inappropriate in that it's being done in an inappropriate area. Either redirect them or take them to a private area. Okay, next. You'll see repetitive behaviors. What you want to do is help the individual move to the next step. Don't tell them to stop. Give them something else to do. So you're redirecting them. Again, telling them to stop is only going to agitate them. And again, you're going to have somebody who's very upset. Next. Okay, offensive behavior. Don't try to reason or contradict. Basically, this is the same stuff we've been talking about with some of the inappropriate sexual behavior and stuff. A lot of times it's words. You'll have sweet grandma who's never said a curse word in her life, unfortunately, will all of a sudden let out a spew of words that you didn't know she knew. Very hard not to react to that. What you need to try to do is ignore the comments and distract the individual. Respond to the feeling you think is being expressed rather than the words. And this, I'm going to tell you, this is the hardest thing to do. Don't take comments or criticisms personally. If this is somebody like your mother or your father, or somebody you've had a long relationship with, our reaction oftentimes is automatic. How it's ingrained in us and how we react to that person. And oftentimes it is very difficult not to automatically take these comments or criticisms personally and try to be able to take a deep breath and take a step back so that you're not reacting to them the way you had reacted to them in the past, especially if you had a difficult relationship with the person you're caring for. Next. Okay, don't try to convince an individual that his belief is incorrect or the hallucination is not real, because to them it is. Reassure and distract the individual, as they're often very upset and very frightened. And one of the things you want to do is reduce clutter and shadows in a person's room. If you've got a lot of shadows in a room, they're, again, like think about a young child. They see the monsters and hiding in the corner. And so is somebody with dementia, because they're not able to make sense of what is happening around them and what their environment looks like. Oftentimes, when you want to distract somebody, oh, I'm sorry, go to the next one. Okay, so what you want to do is a catastrophic reaction is when an individual is upset way out of proportion to the problem. So it might be, you gave them a peanut butter and jelly sandwich at lunch and they wanted a ham sandwich, and all of a sudden they're trying to turn the table over. And it was like, well, all I need to do is I'll get you a ham sandwich. And by that time, it is too late. So again, accept that the individual is not reacting on purpose to get attention or etc. They can't help their response. Take it one step at a time. Your tasks, your requests, just one little step at a time, hopefully will cut down on catastrophic reactions. Reduce distraction when you want the person to do something. Turn off the TV, remove from a group so that all of the chaos that's going around, around them when you need them to do something, they're not distracted. Be calm and gentle. Limit question asking and decision making. Often asking somebody with dementia questions, especially as you get further into the disease process, gets very difficult because they don't have the answers for you anymore. And they sort of know that they should. So it gets very, very difficult for them and very upsetting. And last slide. So some of the things that you want to do is rocking, holding hands, calm music, avoid arguing or explaining when somebody has a catastrophic reaction. Again, the feeling may last longer than the memory of the event. So an hour later, they may still be upset, but they don't know why. The event that happened an hour ago, they don't even remember it. They just remember, they have that, they know that they were upset. And we need to try to respond to the feelings rather than the behavior, talking to them about, I know you're upset, let's see what we can do to calm down, or, yeah, that must have been very scary. Reflect back to them the feelings you think they are trying to express. Okay, so that is the end of the presentation. I realize I went over this really fast. And that's why I did ask Lizette and Lori to please send out my PowerPoint presentation so that you have this stuff. And these are general guidelines. You're going to have to try them with the individual that you have. Not everything is going to work on every individual. And things are going to work for a little while and then stop working, and then you're going to have to try something else. Like I said, working with somebody with dementia is a very, very difficult task. And I always tell people, if you are a caregiver, your best bet is a support group, so that you're talking to other people. They can, give you ideas, you can give them ideas. They can validate your feelings of the things that you're going through. So I highly recommend, if you are a caregiver, get it. You need to take care of yourself, because if you don't take care of yourself, you're not going to be able to take care of your loved one. I know we have some questions coming through, Lizette,
Yes.
Lori, so.
Yeah, there are a couple of questions. Some are in the chat, some are in the Q&A. I just want to say thank you so much. Some of the sentiments that have been posted on the chat, some suggestions. I think this really resonates with a lot of people going through this with their own families. So one of the questions, and you touched on this earlier, was where do you go, kind of what's the most effective screening tool or diagnosis tool? And would you recommend a neurologist or a gerontologist? Or does that really depend on the age of the person?
Except for early onset dementia, I mean, if it's more somebody in their 70s or 80s, the preference is for a gerontologist. Because they really are going to look at not only dementia and why, but also any other diseases of aging. The problem is they're very hard to find. And if you do find one, you might have a wait to get an appointment because they are in big, big demand. So your next best bet then would be a neurologist.
And perhaps the neurologist might know somebody, a gerontologist that they can refer you to, but that would kind of work in the interim.
But neurologists are also experts at disease. I mean, that's what they do. So dementia certainly, and looking for the causes of dementia certainly is within their wheelhouse. I just think for someone who's older, a gerontologist will look at more of an overall picture of some, of all the other issues that happened with someone who is aging.
So also somebody else had asked, puzzles. We hear doing things to keep the brain acute, do puzzles and Sudoku and Wordle, do those things help kind of slow the process?
It's not going to hurt. It's not going to hurt. What you want, think of the brain, it's a muscle.
Right.
So what you want to do is keep it, you want to strengthen it. You want to keep it active. You want to constantly give it novel stimuli to, to work off of, because it keeps it strong, just like it does working out the other muscles in your body. So I always say those puzzles and things certainly are not going to hurt. There hasn't been a lot of research done that shows that they have had a lot of efficacy, but it's not going to hurt.
Okay.
Yeah.
So you had also touched a little bit on kind of the difference between short-term and long-term memory. So
Right.
how much is the long-term memory impacted? And also another question is dementia common with Parkinson's? Because you'd mentioned a couple of
Yes.
other diseases.
So I'll take the easy one first. So yes, dementia is a symptom of Parkinson's. Usually later stage Parkinson's. Okay. And in terms of short-term and long-term memory, short-term memory is going to go first. So they're not going to remember necessarily what they had for lunch or things that just happened immediately, but you can sit and talk about their childhood, and they will tell you about the trip they took with their parents to, the Grand Canyon when they were a kid and the whole bit. But as the disease progresses, that also disappears. But it will go last because it's more ingrained. It's been there. Things that, people, if you've got somebody who's been knitting or crocheting for 50 years, they will be able to continue to do that. They might not be able to follow a pattern, but they'll be able to do the crocheting or knitting because it's something that has been embedded in their brain.
Well, that makes sense, connecting with what you were saying about things like music, the music that they find relaxing, because that's probably somewhere in their long-term memory.
Yeah, because most of us develop our music preferences when we're teenagers.
Yeah, I've heard that.
Yeah.
I still listen to the same music from 1998.
Yes.
So another question, how does this disease ultimately end your life? Is it the slowing shutting down of organs? I mean, apart from external issues.
It does, because it is a disease of the brain. So slowly your brain is deteriorating. And as it deteriorates, if you ever had the misfortune of seeing somebody at end stage dementia, they're usually in the fetal position. Their whole systems start to break down and shut down, and because the brain is deteriorating. The brain is the motor of the body that gets everything sort of functioning, and so when that starts to deteriorate and break down, so does the ability for our body to work.
Right. It's not sending the right signals to where it needs to go.
Yeah.
So, and another question, do you know anything about gamma waves?
No. No.
So, and I don't think there's any, medicine or drugs on the market that really.
So the drugs that are on the market, and one of the reasons I really did not get into the drugs is because I have been retired for 13 years. And one of the things I have to say, thank goodness, is in that 13 years, the medication that they have come out with, it's been an explosion, which is good. There is nothing that will cure Alzheimer's. However, there are medications that they will slow down the process. But for a lot of these medications, you need to catch the disease early on.
Right.
And in my opinion, the tests that are done in doctor's office to assess catch the disease too late. Just so my mother-in-law had she had both vascular and Alzheimer's dementia. And so she had gone, I had said to my husband, I think you need to mention to her physician that I think she's having cognitive problems. And he came home and she said, no. He goes, the doctor said she's doing fine. She only failed 3 of the items on the test. And I'm like, she shouldn't have failed any of them. Because these are things like, although this one I always laugh because they're going to have to change it for the next generation. It's draw a clock face.
They won't know how to draw a clock face.
Exactly. They're going to have to change that one, but it's draw a clock face and show like 5 after 3, things like that. Things that you should not fail any of the items on the test. And I think the tools that are out there have to get a little bit more sophisticated so that your primary physician can pick up on earlier stages so that you can get that medication, which will slow down the process. Right now, there is nothing that will cure Alzheimer's disease.
Right. And I know one of the big issues with any of those kinds of diseases is also the blood-brain barrier. How do you distribute it? How do you get past basically our body's defenses? So it makes, testing very difficult and administering very difficult.
And there's still research being done as to why people develop dementias. And one of the things that I just saw that came out is the diabetic weight loss drugs. They're actually finding that people who are on that have less likelihood of developing dementia. So now the researchers are going, okay, so why is that? They sort of go back now and go, okay, how are they acting on the body in a way that it is helping to prevent Alzheimer's disease? So yeah, the research there's a lot of research going on.
Right. Another question, what percentage of people get dementia?
Off the top of my head, I am not sure because it has changed. As people live longer, you get a higher percentage of people developing Alzheimer's. So it has, there certainly are more cases being diagnosed now than say 50 years ago, but people also live longer now.
Right.
So I would say over 80, it might be like 50%.
Wow.
Yeah.
You had mentioned Alzheimer's and vascular dementia. Somebody asked us what's the key difference there?
Okay, so the key difference to vascular and Alzheimer's disease. So vascular dementia is little mini strokes. Okay. So, and what happens if you think of it like stepwise? So you have a mini stroke, you lose, say, just for ease, so you lose 10 skills. But through rehabilitation, you can get 8 of those skills back. And then you have another little mini stroke. And now you lose 10 skills. And you get 8 back, but now you're at a deficit. So you're slowly losing skills. It's a very stepwise. However, if you can stop the mini strokes from happening, you won't have the progression. So do you have high blood pressure? what's causing these mini strokes. If you can stop that, you can stop the progression of vascular dementia. Also, the other thing too is with vascular dementia, when you have these episodes, again, rehab helps you get skills back. Okay, Alzheimer's disease is just a linear progression. You're just losing skills. There's no getting them back. There's there's no rehab that's gonna, once you've lost a skill, to help you get that skill back, which is why it's really important to figure out why you have dementia. Because again, with vascular, you can stop it, at a point and not progress. Vitamin B, if you have a severe vitamin B deficiency, you will have dementia symptoms.
Yeah.
Yeah.
I know someone with pernicious anemia,
Yeah.
and it was a vitamin B deficiency. And that, I think, kind of goes back to really where you started this conversation of is this something, does it have underlying causes, or is it Alzheimer's? Is it something related to that? And again, going to, knowing your body and going to the doctor, and really kind of taking ownership of your health while you have it.
Yes. And people are, they start to realize that they're losing skills, and something's off, but are afraid to go to the doctor because they think there's nothing that can be done about it, and not realizing that there might be something that could be done.
Okay. So thank you again, Debbie. That was so informative. Also, thank everybody for commenting in the chat. Some people posted some tips that they've used with relatives or just opening up. Sorry, there was something happening in the hallway in my house.
That's what happens with Zoom.
And Helene, I just want to, people don't want to admit there's a problem.
No, it's scary. It's scary. None of us want to not be independent.
Right.
And have to rely heavily on others.
So again, thank you. We appreciate you sharing your passion, your expertise, your time. And as a thank you, the AADC has sent a small gift via regular mail. So we hope you enjoy the jewelry box. Surprise, spoiler. And before we conclude, I would like to invite Eileen Cotter, our new AADC Executive Director, to share a few remarks to wrap up our program. So Eileen, take it away.
Thank you very much, Lee. I am very, very honored and very humbled to follow in the heels of Adelaide Marcus Zagoren as the Executive Director of the AADC. And what an exciting time it is to take on this incredible opportunity. We have so many great programs and events that educate and empower our community of women. Tonight, of course, being an amazing example. Thank you, Debbie. Thank you for sharing your expertise with us. And thank you to Lee and the committee for an amazing choice of lecturers. And thank you also to Laura Zagoren Barron for your steadfast commitment to the AADC. I hope everyone is aware of our upcoming Women's Conference, which is being offered in part through the generosity of the Lynch and Lori Irving Foundation, of which Laura is president. The conference promises to be a full day of an engaging panel discussions, networking, expert presentations on vital topics like wealth management, health and wellness, women in the workforce, all capped off by a keynote address by Stacey Abrams, the former Georgia State Representative, civic strategist, and 5-time best-selling New York Times author. The conference will be held on March 15th, but register today or tomorrow or Friday, but take advantage of our early bird pricing. Just put the link in the chat And you can also go to our own website, douglasalumnae.org, and find it there. And final, very special thanks to everyone who is joining us tonight. Because of your engagement with and your financial support of the AADC, we are able to do everything that we do. And our world needs more women leaders. Because of you, we can continue to engage and educate and empower smart women. So thank you to everyone, and I hope you all have a great night.
Absolutely. Thank you, Lisa.